Hi, I'm Joni Watson, and today I want to share with you about primary and secondary prevention of cervical cancer. We'll cover both primary prevention, meaning what we all typically think of in regards to prevention, such as diet, exercise, etc., and secondary prevention, meaning cervical cancer screening. Tertiary prevention, which includes treatment and survivorship, is absolutely important to improving the health of patients. And all nurses, no matter their specialties or roles, can impact cervical cancer. But for the purposes of this learning activity, we'll focus on primary and secondary cervical cancer prevention. Let's take a good look at the overall picture of cervical cancer, not only in the United States, but also globally. According to the American Cancer Society, over 1.6 million people are expected to be diagnosed with cancer in this year alone in the United States. Of those cases, 12,340 will be cervical cancer, and a little over 4,000 people will die annually of the disease within the United States. Cervical cancer is actually one of the most well-controlled cancers in developed countries, largely due to effective screening methods and new preventive efforts, which we will discuss in greater detail in a moment. Within the U.S., there are actually more endometrial and ovarian cancers diagnosed than cervical cancers, making cervical cancer the 14th most common cancer among women. But globally, cervical cancer is the second most common cancer among women. 85% of all worldwide cases of cervical cancers are in developing countries, and 52% of women who have cervical cancer globally end up dying from the disease. As with most cancers, when caught early, cervical cancer has a much higher survival rate. In fact, cervical cancers caught at stage 1A have between a 93 to 95% 5-year survival rate, which is outstanding. So let's discuss some of the anatomy and pathophysiology of cervical cancer. This is important because many females do not fully understand the reproductive system and can get confused about whether or not they actually need cervical cancer screening. The cervix is part of the reproductive system. It is the lower portion of the uterus where it joins the top portion of the vagina. The cervix has an opening, the os, to allow sperm and menstrual fluid to flow through. The vagina and ectocervix are comprised of squamous epithelium, which is flat and smooth, pink and translucent. It's very similar to your gum tissue. The endocervix, on the other hand, is made of columnar epithelium. The squamo-columnar junction is the line in which the squamous epithelium meets the columnar epithelium, which is a natural metaplasia response due to a surge of hormones, typically during fetal development, puberty, and pregnancy. The transformation zone is very important to remember. It's the area of metaplastic epithelium between the original squamo-columnar junction and the current subcolumnar junction. And 80 to 85% of precancerous and cancerous lesions develop within the transformation zone. The subcolumnar junction, or SCJ, is the line where the squamous epithelium meets the columnar epithelium. The location of the SCJ actually moves as squamous epithelium replaces the columnar epithelium. Now, the majority of cervical cancers are squamous cell carcinomas, and more rare forms are adenocarcinomas. There are often no early signs of cervical cancer, and an abnormal pap smear is typically the first early sign of cervical cancer. Some early stage signs and symptoms may include vaginal discharge, abnormal bleeding, postcoital bleeding, abnormal menses, postmenopausal bleeding, and pelvic pain. Late-stage symptoms can include pelvic or lower back pain, weight loss, bowel or bladder fistula, azotemia, bleeding or foul discharge, unilateral leg edema, and urinary symptoms such as frequency and hematuria. Cervical cancer staging utilizes the TNM, or tumor node metastasis model, as outlined by the International Federation of Obstetrics and Gynecology. Cervical cancer is actually staged clinically, visually, by the physician or provider, so surgery does not change the stage of the disease. This allows staging to occur in low-resource settings. Cervical intraepithelial neoplasia, or CIN, is a spectrum of precancerous changes. It takes years for CIN to develop into cervical cancer, but left untreated, CIN will develop into cervical cancer over time. As with all other TNM cancer stagings, stage 1 is local disease, and the staging progresses to widespread metastatic disease. All right, so here's the primary cervical cancer prevention piece, what we all typically think of in regards to prevention. This prevention is appropriate for everyone, all ages, all populations. Cervical cancer has both modifiable and non-modifiable risk factors. Modifiable indicates the risk factors are items that females have control over and can change. And the non-modifiable risk factors are issues that females clearly cannot change. They are non-modifiable. So in regards to risk factors, clearly you need a cervix in order to be at risk for cervical cancer. So being female is the number one non-modifiable risk factor for cervical cancer. The number one modifiable risk factor for cervical cancer, though, is lack of screening. Considering that there are no early signs and symptoms of cervical cancer, we utilize screening, in this case the Pap smear, to detect cervical dysplasias or premalignant cells. Between 60 to 80% of women with advanced cervical cancer did not have a Pap test within the previous 5 years before diagnosis. So this indicates the importance of screening. Even women who are not regularly seeing a gynecological provider need consistent reminders from primary care providers and other providers to have their regular screenings. There are over 150 human papillomaviruses, or HPV strains, and more than 40 of them are spread through vaginal, anal, or oral sex. HPV is detected in 99% of all cervical cancers, as it is the number one initiator of cervical cancer. And 2 HPV strains, strain 16 and strain 18, are responsible for the majority of cervical cancers. It's important to ensure our patients are aware that HPV is not the only cause of cervical cancer, though, as the Centers for Disease Control and Prevention estimates that at any given time, nearly 50% of all females are infected with HPV. 80% of all women will have HPV in their lifetime. However, 95% of women clear the infection naturally within 3 years. It's the remaining 5% of females that cannot naturally clear the infection that is concerning for risk of cervical cancer. There is also a currently unknown link between chlamydia infection and cervical cancer. As with HPV infection, some researchers believe those patients with immunosuppression, which is a large group of people these days as a result of comorbidities and current pharmacotherapies such as steroids, leads to risk for greater HPV and chlamydia infections. Oral contraceptive and intrauterine device, or IUD, use are risk factors for cervical cancer as well, as women who use these contraceptive methods are less likely to use barrier devices, which can impact HPV infection. Young age at first full-term pregnancy is a risk factor, as is multiparity. Multiple childbirths increases the risk of cervical cancer. For example, women who've had 7 or more childbirths have a 4 times greater risk of cervical cancer than their counterparts. DES, also known as diethylstilbestrol, was a synthetic hormone given to women between 1941 to 1970 in order to prevent miscarriage. It's actually the DES daughters who are most at risk for cervical cancer as a result of the hormone. Smoking is also a tremendous risk factor for cervical cancer, as it is for nearly 15 other cancers. Diet, as it relates to obesity, may be a risk factor for cervical cancer, and poverty is also a known risk factor as it may impact numerous other risk factors, including screening practices. Ethnicity is a non-modifiable risk factor for cervical cancer. For example, there are certain racial and ethnic groups, such as Hispanics, African Americans, Asian, specifically Vietnamese and Korean, and Native American women who have increased cervical cancer risk. So now that we know about the risks, let's talk more about the specific cervical cancer screening methods. There are well-researched, evidence-based strategies for preventing cervical cancers. Females can change their modifiable risk factors, engage in HPV infection avoidance strategies, and participate in screening. Screening is the key for cervical cancer prevention. In regards to the modifiable risk factors, smoking remains a tremendous risk factor for females in cervical cancer. A 1992 study actually showed that nicotine substances are found in cervical mucus secretions, indicating that nicotine does indeed reach the reproductive system and is impacted by it. All females who smoke should be encouraged to stop smoking at every provider visit using an evidence-based model. Nurses should take a thorough history and physical to assess for tobacco use as well as secondhand smoke exposure, since that is a contributing risk factor as well. Women should be encouraged to maintain a healthy weight through a balanced diet and regular, intentional physical activity according to the guidelines set forth by the American Heart Association, the American Cancer Society, and several other public health-focused organizations. In addition, barrier contraceptives may help prevent against HPV infection. And HPV infection avoidance is such a large and vital modifiable risk factor that I wanted to discuss it separately. According to the NCI, the surest way to eliminate risk for genital HPV infection is to refrain from any genital contact with another individual. Altering current or future sexual behavior can reduce the incidence of HPV infection. It is important to assess what females think of in regards to quote-unquote sex, as many females believe only vaginal penetration is considered sexual intercourse, which can lead to HPV infection. As mentioned earlier, HPV is a genital-related infection, so it can be passed vaginally, anally, or orally. In addition to reducing the number of sexual partners and sexual contacts, the HPV vaccine is a tremendously effective method to avoid HPV infection. Currently, there are 2 HPV vaccines, Gardasil and Cervarix. Gardasil is known as a quadrivalent vaccine because it covers 4 HPV strains, strains 6, 11, 16, and 18. Cervarix, on the other hand, is known as a bivalent vaccine because it covers 2 HPV strains, strains 16 and 18. And if you remember back, strains 16 and 18 are the 2 strains that cause the majority of cervical cancers. Both vaccines are targeted towards females ages 9 to 26, Cervarix around age 25, and both are a course of 3 injections over 6 months. At this time, only one series of the 3 injections is needed for HPV antibodies. Current research surrounding the vaccines is occurring, though, to ensure appropriate immunity over time for sexually active females. HPV is an initiator for other cancers, including vulvar, vaginal, anal, penile, and oropharyngeal. Therefore, males ages 11 to 21 are now included in the Centers for Disease Control and Prevention HPV vaccination recommendations. The CDC estimates nearly 21,000 cancers are preventable through HPV vaccination alone. The vaccines are made with non-infectious HPV-like particles that help immune systems build antibodies toward the virus. This is important to remember because many people believe the virus is a live virus or may actually cause HPV, which is untrue. It's important for females to finish the series of 3 vaccinations over 6 months in order to have full immunity. Information from the last National Health Interview Survey in 2010 indicated only about 30% of 11 to 12-year-old girls and 23% of women aged 15 to 26 years old initiate or even begin the vaccination series. About 14% and 56% respectively actually complete the 3 vaccine series, indicating we have a lot of opportunities for improvement to increase HPV vaccination initiation and completion. The largest HPV vaccine initiation barriers for women ages 18 to 26 were lack of insurance or the cost of the approximately $400 series as of 2013, and lack of knowledge about the vaccine. For girls ages 11 and 12, the greatest parental barriers were, "My daughter does not need the vaccine," or they were worried about safety, or parents indicated they did not know enough about the vaccine. Nurses can make a tremendous impact in these areas. A pap smear may be done in conjunction with a pelvic exam, but not always. So it is important females know the difference, as some may believe a pelvic exam is screening enough for cervical cancer. The pap test, or smear, was developed by Dr. George Papanikolai, and it was accepted as a screening tool in 1941. It has decreased cervical cancer mortality over 50% within the last 3 decades by detecting precancerous and cancerous cells via scraping cells from the cervix, the transformation zone specifically, in order to view them under a microscope. The HPV DNA test, on the other hand, is an additional test, and it tests for the actual human papillomavirus, which can initiate cervical cancer. I mentioned the global burden of cervical cancer early on in this activity. I've had the opportunity to talk with nurses around the globe, and interestingly, in developing countries where the pap smear is not available, they screen women for cervical cancer using a method called VIA, V-I-A, or visual inspection with acetic acid. Acetic acid is basically vinegar, and the community health workers are trained to swab a woman's cervix with the vinegar. They then view the cervix with a halogen light, and white cervical neoplasms are visible as a result of the chemical reaction. Again, remember cervical cancer is staged clinically, which is important for developing countries that have higher rates of cervical cancer. There are several organizations with recommended cervical cancer screening guidelines. These guidelines have changed quite a bit over the last few years, so bravo to you for working to stay informed on this topic. The American Cancer Society, the American Society for Colposcopy and Cervical Pathology, the American Society for Clinical Pathology, the United States Preventive Services Task Force, and the American Congress of Obstetricians and Gynecologists all have guidelines for cervical cancer screening. All of the organization's screening guidelines mirror one another. ACOG, or the American Congress of Obstetricians and Gynecologists, expands their screening guidelines a little bit further than others, but for the most part, all organizations agree that screening should begin at age 21. And for women ages 21 to 29, those who have a pap smear and then have negative cytology should be screened every 5 years. For women ages 30 and above with negative cytology and HPV tests, they should be screened every 5 years. And women aged 30 and above with negative cytology only, meaning they haven't had an HPV test in addition, should be screened for cervical cancer every 3 years. It's important to remember that screening for cervical cancer does actually have a stop date or a stop time frame. So women aged 65 years and above should not be screened for cervical cancer. Or if women have had 3 consecutive negative pap smears or 2 consecutive negative HPV tests in the last 10 years, they too can stop cervical cancer screening. These guidelines may be different than what you're seeing practiced in your community. Now that you're becoming more knowledgeable, speak up, share these guidelines, and ask questions. It's important that we practice within the evidence base and provide care according to expert national guidelines. There are numerous physical, emotional, and practical barriers for women to have recommended HPV testing and Pap screening. Nurses should be aware of these and anticipate providing additional resources, many of which are available in conjunction with this education activity to help women with secondary cervical cancer prevention. One excellent resource all nurses should be aware of and use is the National Breast and Cervical Cancer Early Detection Program, which offers free and low-cost breast and cervical cancer screenings to eligible women. Specific information about this resource and others are located at the end of this educational activity. Nurses are key to improving health and wellness for all, including cervical cancer survivors and their families. Nurses can affect the public's awareness and willingness to use screening measures that can detect cervical cancers early, increasing the opportunity for cure and survival. Thank you.